how many? Around 18 people who have joined in already.
Yeah.
Point in making them. Okay. Good evening, participants, and welcome to another session of Listen to Your Body. I think we have around 18 people already on board and expect few more definitely to join in. The subject is so interesting. I'm sure people will be more keen in knowing about it. It is my privilege to introduce Dr. Aravinda Mukherjee, a distinguished senior neurologist with nearly 5 decades of experience in the field. An alumnus of the University of Calcutta, Dr. Mukherjee completed his MBBS in 1975, followed by MD in General Medicine and DM in Neurology. He also received specialized training in electrophysiology in the UK. His areas of expertise include epilepsy, multiple sclerosis, and other demyelinating disorders, peripheral neuropathy, and stroke. A gold medalist in both MBBS and MD examinations, Dr. Mukherjee has been an examiner and thesis guide for National Board of Examination and has contributed extensively to neurological research through publication, book chapters, and editorial work. He has also served as president of the Indian Academy of Neurology and was the founder secretary of the Indian Epilepsy Association, West Bengal chapter. We are indeed fortunate to have such an accomplished and respected neurologist with us this evening. Dr. Mukherjee, a very warm welcome to you.
Thank you.
And we look forward.
Thank you so much.
Well,
thank you.
Enriching and insightful session from you. Over to you.
Good evening. I think I'm audible.
Yes, you are.
Okay. Good evening. It is my pleasure and honor to be here this evening. Thanks to Mr. Praveen, and Mr. Arun, Goduli, and all of you for inviting me. I remember I was here in maybe if 1 year or a little more ahead behind. So I talked on dementia, and which was probably appreciated by the participants. So when this time Praveen called me and wanted to know what subject I would like to speak, I thought that I should choose a subject which will be interesting to the participants. And as including myself, we are approaching the senior citizen group. We are in the senior citizen group. So I think one of the major problem which comes and which leads to complicated issues are the fall and loss of balance in the elderly. In my clinical practice, I think every day I see 1 or 2 patients come with these symptoms, and sometimes these symptoms may not be actually benign, but they may cause serious complications and life-threatening disorders. So Arun agreed, and I chose this subject. So my flow will be that I will give you why I chose this subject, what is the magnitude of the problem in the elderly populations, and why we lose balance. For that, I will go a little bit scientific on how our balance is maintained. It is a very complicated thing we don't understand unless we lose it. And then we will go into some of the conditions which prepone us to falls and loss of balance. And this will be followed by a very quick check on what we should do, what tips we should take to prevent the recurrence of fall, etc. So with this, I may share my screen. Sorry, give me 1 minute time. I didn't open the...
think Kaushik has to give permission for sharing.
Yes.
Doctor, if you need assistance, Kaushik can help you.
Kaushik, is it showing up?
Hi, this is Kaushik's wife. No, it is still not showing.
Say that again. Kaushik is not there.
No, this is his wife. Can you hear me?
Can you handle?
So I'm trying. If it's a problem, just tell me. Is the screen shared?
Not yet, doctor.
So I'm sharing it.
Mrs. Kaushik, do you know how to check permission?
No, the permission is already given. Permission is not needed to share.
Yeah, it should not be needed.
Can I step in?
Yeah,
Sure.
please do.
If that is going to work, you show when you open the share window,
Yeah.
it will say either entire screen or window. And your is your PowerPoint open?
Yeah, your entire screen or window, I can see that.
When you click on the
Window,
window,
Kaushik.
your
Then-
PowerPoint will show
Click
up.
on the window. Okay.
Click on
Is the
PowerPoint. Yeah.
Is it open already, the PowerPoint?
Yes.
Okay, then did you see that PowerPoint?
Is it on the screen?
Is it open on the desktop or is it on
Yeah,
the
it is open on the
taskbar?
desktop.
Okay. Then can you see that PowerPoint window?
I have done that.
Click
But
that.
is it on the screen?
Click on that and then say okay.
And then there will be a button at the bottom. You can just click on the button.
You'll have to say okay. After you select the window, say okay.
Yeah, it's selecting the window.
Do you see the button at the bottom?
Give it to me.
That's like the OK button.
More, huh?
Or you can do the entire screen. That becomes easier. Sometimes if the window doesn't take, you can do the entire screen also.
I've done that. Can you see?
Not yet. No, not yet.
Kaushik?
Is it there in your... Sir, Kaushik ne ami handle korchi. Is it there in your phone? If you can WhatsApp me.
You tell me step by step, right? I'm clicking on the share button. I've opened my PowerPoint. Clicking on the share button. Then it show Chrome tab, window, or entire screen. Where should I go?
You click the window.
Window.
And then you will, and then there is an OK button. The way ma'am is saying.
Okay, तो कहाँ पर है?
नीचे है.
You have to first click on that PowerPoint in the window.
Yeah.
Just window won't do. You'll have to click on the PowerPoint presentation that shows up on the window. Then you will get okay.
I'm not getting that. It didn't happen last time. It was easy.
Are you doing it from your laptop?
No. Yeah, laptop, yes.
Yeah, laptop. Or if you can send a mail to me or WhatsApp me, then I can open it here. That's not a problem.
Let me try once more.
Yeah. Yeah. It is showing sharing. Yes. It has done. Now, you go to the PowerPoint, you will be able to see it.
Yeah. Can you see?
Yeah, we can see.
Then okay, right?
Yeah, it's okay.
Yeah,
now
but,
you go to the PowerPoint.
But open the PowerPoint now.
I've opened it.
But we don't see that.
PowerPoint has not come yet. It will take some time. Now I can see you.
It should show up, right?
What can you see in your screen? Can you see
Fall,
the
yeah, fall in the entirely. That's what I can see. And in the bottom, there is one blue called stop sharing. So it must be sharing.
No, that is only sharing and stop sharing.
Yeah, I'm not stopping. So
But
it should be.
PowerPoint, if it is showing,
Yeah, it is shown
just
on my
open the
screen.
PowerPoint.
I've opened it. It is not showing.
No.
we can see your screen. Do one thing, you do the entire screen.
I did it on the entire screen only.
Okay, now what can you see? Because you're
I
sharing
can see there is a sort of entire screen and there is a short logo and my background. So now I open the PowerPoint, right?
Yeah, because the sharing has not yet started now.
I've opened the PowerPoint.
And after opening the PowerPoint,
Yeah, my screen shows only PowerPoint then.
and then that OK button you have to press.
I don't see any OK button.
At the bottom, you will see share. You'll have to go on to share.
That I have done. See, I'm starting from the beginning. I'm sharing the share button. And then it comes Chrome tab, window, and entire screen.
Okay. Could be that you're seeing all the participants, the gallery. See the view and gallery view.
Or in the entire screen, you should put entire screen. My son is telling that. Press on the entire screen.
I've done this.
And then I will click on entire screen, click on that entire screen button, and then again.
Yeah, click on the entire screen button and again click that.
Click what? Entire screen I've clicked.
Entire screen to select. There's a box of entire screen.
To select, the entire screen.
There's a box over there.
You may have to scroll down to see the OK button. Maybe it is down below. If you scroll down,
button is there. You select that entire screen, and then you have to select entire screen below. So there is one button over there. A kind of a window is there, entire screen.
In the bottom, there is a share button.
So once you
you click the share button. Yes.
Yeah, I clicked it. And then I open the PowerPoint.
Yes,
it's done.
now you are in.
It's come now.
Yeah.
It has come?
Yeah.
Yes.
Falling under the Arvind Mukherjee. Yeah, it's come.
Yeah. Okay, I'll just go into slides.
Make it full screen then.
Okay. Can I start?
Yes.
It's all right now.
Sorry for the glitch.
No, that's okay. That's perfectly all right.
So my topic today is to discuss, as I told, the fall in the elderly. So why I chose this subject, that while I was going on preparing for these talks, I looked for some of the datas which are there, and it says that falls are the leading cause of injury and hospitalization among adults aged 65 and older, and 1 in 4 adults experience a fall each year. So fall is not only a very common cause of morbidity, but also it can lead to difficult and complicated situations. Fall-related injuries can include serious injuries like hip fractures, head trauma, and other serious injuries. And also, once a person falls, the fear of falling can lead to reduced activity, and then it causes further weakening of the balance and increasing imbalance and increasing future of fall risk. So in that way, one fall is actually lead to a cycle of events which goes on, causing more disability and more imbalance and risk of more falls. But also we know that understanding these causes of is essential for preventing falls, improving safety, and maintaining independence in older adults, which we all want to do. So I will just take two slides or 1 minute to discuss. I think everybody should know and appreciate that we are walking without falling and without imbalance. It's not a very simple task. So this slide very briefly mentions how a human being who are different from quadrupeds and maintain their balance. And as we can see, if we start from the left-hand side, there are three major components to maintain our balance. One is the efferent component, that is the input. And it is mainly the sensory input and three organs which continuously feed our brain, which is the main CPU for balancing, are the vestibular system, which is located inside our inner ear, and three semicircular canals, which my doctor friends will understand. And this vestibular system input always keeps informing our brain about our equilibrium in the space, our spatial awareness. If we rotate, it informs immediately our brain that we have rotated, so make a necessary connection. Also, without rotation, if we make a linear movement, the brain immediately gets information from the vestibular sensory input. Second most important input is from our vision. Like we are continuously seeing things that not only we are appreciating the beauty of the things, but it also gives us, the brain takes feedback from our vision, where we are, what is on our surroundings, and how we should behave, our motor activity should continue. And third, and also very important, is the proprioceptive, which is from our nerve endings, especially in the lower limbs as we stand. There are different types of nerve endings, and one of the nerve endings is connected with our balance, which is the proprioception. That means by this sensory input, we understand what is our posture, where we are standing, and etc. So these three sensory inputs are absolutely essential, working day and night, years after years, every minute, even while we are sleeping, to keep our brain, which is the central processing unit for balance, so that we can maintain balance in the space and in the surrounding. What is the CPU composed of? It composed of certain parts of the brain, like most importantly, the hindbrain, which is the cerebellum. It coordinates and regulates our posture, movement, and balance. But also higher brain, which is the cerebral cortex, these also contribute because based on the input and coordination of the cerebellum, the cerebral cortex, they formulation what activity we should do, and this is a higher control of gait, which we say in our terms. So once this integration program is handled, every millisecond this integration program is being handled by the CPU, the brain. They then set the output, what to do. How they send the output? There are three pathways. One is the vestibular ocular reflex. I'll give you a very simple example each of you can do. You just hold a finger or an object about 10 inches in front distance from the front of your eye, and you rotate your head, and automatically and unknowingly your gaze will be fixed on that particular line. Normally, if it was not contributed by the CPU and the input system, if you rotate your head, the particular object you are viewing will be out of your vision. But because of this vestibulo-ocular reflex, your gaze is fixed on that particular object. When we are at the end of the meeting, you can practice that. So this is a very important balancing mechanism continuously working through our brain input system, the computer CPU system, and the output system. It also sends through the integration and the brainstem area, the motor impulses, like how, if you are going out of a range of your movement, you are going to fall. So immediately the whole brain sends you a signal, they correct your posture, otherwise you are going to fall. So this is also a very important thing to keep our balance and prevent from falling. So these are the a very complicated thing which is continuously being done by our brain and the sensory inputs and other parts of the nervous system. And we don't understand the utility of this unless we lose one of them. Like if you lose vestibular function, you have vertigo and you are falling, then you understand what this very vestibular function was keeping you in balance all through your life. A little bit more detail. I could not resist my temptation to project this sliding. It may be a little bit scientific, but I just read out. So balance is never static. We think we are standing, so we are in a static statue position. It is not that. Human balance is never static. You are continuously making movements. Your feet are moving, your hands are moving, your eyes are moving. So this is a dynamic process and we call it a body sway, which in small corrections are continuously made to maintain stability. So even if you are standing, thinking that we are not moving, the brain is idle, it is not that. We are making micro movements and the brain is continuously trying to stabilize so that we don't go out of balance. These adjustments are orchestrated by the central nervous system in response to information provided by three sensory systems, as we just told. For example, when you stand, your body is constantly making micro adjustments to compensate for involuntary movements and maintain a stable posture. I think we should always think in mind how important and how tirelessly our brain working, even if we are sleeping or we are unknowing that the brain is continuously working to keep our balance. However, this process is not infallible. An imbalance can occur if one of the sensory system is compromised or if communication between this system and the CNS, which is the CPU, is disrupted. This can happen as a result of variety of factors. One factor is definitely the age. It may also be due to certain neurological diseases, injury, or even simple lack of fitness. So I think this is a very basic concept with which we'll move forward about our balance and fall. Now come to more a practical aspect. Who are at the risk of fall in the elderly? As I told, anybody above the age of 65 have increased risk of fall, and if you go aging, it also exponentially increases the risk. Like a person at 65, a person at 75, a person at 85. The 85-year-old have more chance of risk of fall than the 65. So risk of fall rises with advancing age. For some reason, I do not know why, women are more prone than men. One of them may be the osteoporosis, osteopenia, etc. But there may be some other reasons, maybe their attitude, their fitness. And the certain comorbid contributors, we all know, like this increases the risk of fall. So if we have this diabetes, obesity, osteoporosis, arthritis, muscle weakness, deafness, or compromised vision in any way, either for retinal or for correcting glass, we are at higher risk of fall. We should always keep in mind, take adequate steps so that no accidents happen. So this can be further categorized, and it may be repetition that some causes are peripheral, like muscle weakness, slow reaction time, poor balance, even foot arthritis, compromised vision, compromised hearing, and most of them can be reversible by adequate measures. Central cause, if you have cognitive defect, like you have memory loss, you have a patient of Alzheimer's disease or dementia, you are more at risk of fall. Certain medications, with the advancing age, our list of daily medication also increase. So I will give you a synopsis of what medications are usually responsible for causing high risk of fall. Some BP fluctuations, we take BP medicine, but we don't record it regularly, but some BP fluctuations also are results of fall. Certain CNS diseases, which I will talk about later, like Parkinson's disease, stroke, and ataxia, they will make the person more prone for fall. So if anybody is suffering from disease, if their relatives or their seniors, then they should be taking extra caution. Some environmental factors which we overlook but which can easily be managed are the factors like slippery floors. Often the rugs we use are folded or they're ruffled. So we trip. It is very common accident to trip on these. So please don't do that. Home cluttering is one thing, with our advancing age, our orientation of the space diminishes, our vision compromises. So if there is a cluttering, we may trip on certain things and we may fall. And dim lighting is also very important. Please keep your house well lighted, particularly the rooms or where the seniors will roam about. So this is on the left-hand side, the picture module of the factors we have talked. It is, I think, if I repeat it, you will remember it. So the common fall risk are muscle weakness, poor balance, impaired vision, reduced bone density, certain diseases I have told, Parkinson's disease, dementia, and certain environmental hazards and medication side effects. Coming to the medicines, I will go that we all take medicines and we have to take medicines. Like if I am a diabetic, I have to take diabetes medicine. If I have got hypertension, I have to take hypertension medicine. But what is most alarming are the use of sleeping pills. We use sleeping pills very commonly, and sleeplessness is a very common factor in old age and senior people. But some of the sleeping pills, which are known as benzo drugs, like we take benzodiazepines, or the Z drug. The benzo drugs we commonly take are the alprazolam and clonazepam, diazepam, etc. And the Z drugs we use are commonly known as Zolfresh or like this. So both these benzo drugs and the Z drugs, they make your balance compromised. So taking these drugs days after days, year after years, without consulting your physician is going to reduce your cognition, and not only cognition, it also affects your balance and make your risk of fall increases. Certain antidepressants are also increase your chance of fall. Opioids, we don't take it normally, but many of the painkillers, I will tell you, we don't know that very certain common painkillers, they contain some small portion of opioids. So we may take it for a short period, but during that period, we must be very careful about our fall risk. Diabetes medications, yes, they may cause fall by the two ways. One, that diabetes, because of its own disease, they can cause weakness of your nerves and thereby reducing proprioception. And diabetes medicine also can reduce your blood sugar to a dangerously low level so that you have a risk of syncope and fall. The other medications are anti-epilepsy medications, antipsychotic medications, certain muscle relaxants, prostate medication, and medication that dilate the blood vessels. I will not deal with each of them, but I will have one word about the prostate medications because male members of the senior citizens, they do have prostate problems, maybe more than 50% of them. And they are prescribed medicine to retain their urine flow. And these medicines are basically mostly are alpha blockers. There are two types of sympathetic blockers. One is the alpha and one is the beta. So in prostate medicines are mostly contain alpha blockers. And one of the major disadvantages of alpha blockers is they compromise our normal physiological mechanism to maintain our balance when we stand up from a lying position. So what happens that when you're lying, your blood pressure is maybe at a normal range, but as you stand quickly, the mechanism is lost because of the alpha blockers, and there may be a precipitous fall of the blood pressure, and that may cause transient loss of consciousness and fall. So those who are having these symptoms of syncope or dizziness on standing must check their blood pressure on supine and standing, and if it is so, you must tell your urologist to change the medicine from alpha blockers to something different type. I'm coming to the diseases which are have increased fall risk. Vertigo, we all know if there is a vertigo, we are very difficult. Anybody who has got a vertigo, they know how difficult to stand at that time. And the Parkinson's disease, Parkinsonian syndrome, I think somebody in the audience will have someone suffering from Parkinson or has seen some Parkinson's disease. So the three components of Parkinson's disease are tremor, rigidity, and loss of balance. So apart from the disease, the loss of balance is a feature of Parkinson's disease. So they should be very, very careful. Post-stroke defect, particularly if there is a hemiplegia or some cerebellar dysfunction. The polyneuropathy, as I've told, the commonest polyneuropathy is because of diabetes, and the second common is because of B12 deficiencies. They have their loss of proprioception because the input is not correct, the CPU cannot act properly and increase your chance of fall. BP fluctuation, about postural hypotension, I just told medication, I will come in the next slide. And also those patients who are demented, they are cognitive and visual spatial disorientation. So they have an increased risk of fall. So let us see my question that do you know, if I ask you, are you balanced? So balance in life, there are two aspects of it. In a lighter mood, like we are always balancing our life, not from the medical point of view, but from the socio-economic point of view, because throughout our life, we're balancing with our family, with our friends, with our career, with our health, with our economy. And everybody who has a family knows how difficult it is to do. And sometimes we slip in the balance and cause catastrophe. But at the right-hand side, this picture shows that this is something which is trying to balance on a rounded surface. So our today's discussion will be on the right-hand side. Are we really fit enough to have balance, or how can we know that we are not fit enough and we are not to maintain balance in case of any difficulty? So there are two types of tests I will discuss, and I think everybody should do it at least once in 2 weeks or once in a month to see how they are keeping their balance, which you normally don't do. So these tests are stage 1 is stand with your feet side by side, almost touching your feet. So to further reinforce this test, you stand with 2 feet close together and then stretch your arms. And then if you are steady, close your eyes. In our language, you call it a Rombach sign. So if you can maintain at least 10 to 20 seconds with your closed eyes and standing feet together, then you pass the test. You are well balanced. Further going ahead, the stage 2 is the place the instep of one foot so that it is touching the big toe of the other foot. You can do it while I'm reading and see if you can balance it. And if you are past this test, then do the tandem stride and tandem walking. Tandem walking is to make your heel touch the toe of the other foot. You stand for 10 seconds. If you are not swaying, then you walk for about 20 steps, heel touching your toes. And this you can do forward as well as backward. So if you pass all 3 tests with good results, then you are safe, your balance mechanism is working. A further difficult one is this test. I think 50% of us will not be able to do it. I cannot do it. So this person is standing, and then while you're standing with your hands folded, you take one of your leg and touch your heel of that leg with the knee of the other leg, like this posture, and hold it for 10 seconds without wobbling or without your footing down. And if you can pass this, that if you can hold it for 10 seconds, then repeat it with the other leg in the same fashion. So if you pass this balancing test, in a 4 steps test and the heel touching knee test, then you are probably quite safe. With this basic knowledge, I will give some very practical case presentations which I have come across in my clinical practice. First case is a 70-year male consulted with history of recurring fall during the past 6 months. Most of these episodes happened at midnight when we had to go to the restroom for urination. The episodes were associated with transient reversible loss of consciousness, which we call in our language syncope. So this 70-year-old gentleman has history of recurrent syncope during going to the restroom, getting up from bed at the midnight. Past history, he is diabetic, mildly hypertensive, suffers from benign prostatic hyperplasia, which he started some prostate medicine. That most of these prostate medicines are alpha blockers. A medical examination, nothing great. He was extensively investigated with CT scan, ECG, everything was normal. But when we tested his blood pressure, when he was lying, it was normal, 140 by 80. But standing blood pressure dropped to 110 and 60. So we know that if there is an abrupt fall of blood pressure of more than 20 millimeter, then the patient is definitely going to have syncope, dizziness, and fall. So this was diagnosed, the syncope due to postural hypotension, most likely caused by the prostate medicines, which are alpha blockers. And this is definitely a treatable condition. The second case I would like to discuss is a 58-year-old female presented at the emergency room at midnight with history of severe pain in the left hip since evening and inability to move her left leg. Examination revealed the lady had signs of Parkinson's disease, tremor, rigidity, and bradykinesia. She was diagnosed as a case of idiopathic Parkinson's disease since last 1 year and were on medications like Syndopa and Ropa. And this time, when she landed in emergency after the fall, the X-ray shows a fractured neck femur. So she was diagnosed as a cause of neck femur left fracture. And this has got a serious complications. So the reason for presenting this case is two. One is that anybody suffering from this particular disease had got increased risk of fall. And that fall is not always benign because here there is a major complications of fractured neck femur, which will cause disability in that particular lady for a longer time. Now see what we can see in this case. 58-year-old female, diabetic, and these are all very common situations. I think most of our listeners, some of them actually suffering from them. 58-year-old female diabetic. Sorry?
Scanner है ना क्या? Scanner ही है.
Diabetic for 8 years, noticed loss of balance while walking for 1 year. On 2 occasions, she had fallen due to loss of balance without any serious consequences. Examination, normal motor power, cognition, she had reduced vibration sense in both lower limb. Distally, Romberg's test was positive, beat was not bad, 130/78 and standing. So he had on electrodiagnostic test bilateral axonal sensory motor polyneuropathy. So here the take-home message will be that a diabetic polyneuropathy, which is a very common association of long-standing diabetes mellitus, is a major factor for causing loss of balance and fall, and everybody who has had diabetic should be tested for diabetic polyneuropathy. I come to one of the cases which important to show how important it is to prevent the risk of fall. This is an elderly male with history of CABG, that means bypass graft, and he was on dual antiplatelet for that. Once he slipped on a wet floor 10 days back. Nothing happened at that time, but after that, he developed progressively increasing headache since 1 week. And over last 3 days, he was noticing walking difficulty and dragging the left lower limb. He was examined by a neurologist who immediately asked for a CT scan. And this scan, you can notice that on the left-hand side of on the right-hand side of this scan, left-hand side of us, the brain parenchyma is absolutely normal. But if we look at the other side, you can see that there is something which is very promising. You can see this is absolutely clear, normal brain parenchyma, but here you can see there is an difference of the density here and here, and this is actually blood, and this is inside the cranium. This is the cranium, and this is the blood, and because of the blood, this brain has been pushed to the other side. So this is called typically acute and chronic subdural hematoma. And at the elderly age group, even a trivial fall, particularly you are having on blood thinners, like in this case, there are two blood thinners. This may cause a massive subdural hematoma, which will need immediate surgical procedures. Otherwise, there will be a lot of complications. So fall prevention, I put this slide to emphasize that fall prevention in the elderly is, I think, one of the most important things to consider. This may be a little complicated. I'll just briefly go. This is another type of disease which is very treatable. So if you have someone who have over elderly male having some problems of gait imbalance for months, and sometimes there is a fall due to loss of balance, and this is associated with two more features, that forgetting things, loss of memory, and there is a difficulty in controlling urine. This is a treatable condition. As we can see, these, if we have seen the normal scan in any person, there is the ventricular system is dilated. This is a normal pressure hydrocephalus. I put this slide to emphasize that this is a very much treatable condition. We see patients who's been neglected with these symptoms, but when they come to us, just a simple shunt that changes their life. This is PD. I'm not going into details. This is one of the factors which I emphasize on all my patients, including my wife, to see that, there is a 58 story of a 58-year female diabetic. He fell on the street and sustained fracture of the right wrist. So if we look at the insight, she had recently changed her glass with a progressive lens and talking on mobile while walking. So here are three factors. Diabetic, maybe the proprioception was not correct. Because of the recent progressive lens, the surface evenness is not there. And because talking on the mobile while walking, she was distracted. And what happened, she could have avoided all, except the diabetes, she could have avoided that, could be more cautious. So she had a right state fracture, we needed plaster and use of the restricted use of the right limb. So this is all about the theoretical aspect, but you will ask what to do when a person in our house has fallen. So if there is a fall in your house, elderly person, maybe most commonly situation is that he has gone to the bathroom and then while passing urine, or just after passing urine, he fell down flat on the bathroom. And because of the loud sound, you rush there and find that he is lying on the floor. So don't panic. This is number one. Number two, put the patient in a comfortable position, flat or head down, never head up, or never try to make the patient sit up or stand. Put the flat, or if possible, put something under the leg so that the head is at down level. Check for any injury, especially any head bump, or immediately check the hip joint, because that is the one area we are very much concerned about, any swelling, any redness, or etc. Look for level of consciousness, she has passed or any stool or urine unknowingly. If conscious, inquire about the situation before the incidents. So many patients will give you a very clear story that as in the midnight he was going to the restroom, trying to pass urine, he suddenly felt dizzy, tried to control, but since there was nothing to hold, he couldn't control and fell flat. So this is a typical story of a condition called micturition syncope. And then if he is conscious, let's quickly check that if he or she can move all four limbs. Then you are safe that there is no paralysis, no stroke. This is probably a simple syncope, and maybe he has not suffered any serious injury. If possible, if you have a BP instrument, just immediately check the BP. If the patient is diabetic and if you have provision for maintaining the blood sugar, many of the diabetics have this sugar checking mechanism instrument. Check immediately the capillary blood sugar by a pinprick. When stabilized, put the patient in a bed in flat position and put him to sleep, but somebody should be with him for that particular night. Then you go to take him to a clinic, because anybody who has a fall will approach the clinic, maybe general practitioner, consultant, or the neurologist. First thing the clinician to do the history. What is the incidence of fall? If there is a fall in before, was he suffering from any comorbid diseases? Then a thorough examination, particularly to rule out any head-related injuries or any fracture anywhere, particularly hip fracture. And accordingly, he will plan investigations like blood hemoglobin, fasting sugar, X-ray, if required CT, MRI. Also, if we think that this could be related to heart, maybe he will advise you to go for ECG Holter, and sometimes head-up tilt test, which measures the standing and supine blood pressure, and accordingly plan treatment and advise steps to prevention for recurrent fall. So, in summary, at the end, I will give you 6 tips to help prevent falls in the elderly. So, number 1 is that talk with your healthcare provider about medication side effects. If you are imbalanced, if you have one episode of fall, immediately inform your healthcare person that these are the medications I'm taking. Can any of these be responsible for the fall? I think this is step 1. Then you do some strength and balancing exercises. Make your home safer by using night lights, installing grab bars in the particularly in the bathrooms, and securing carpet to the floors. In many of the houses, the carpet corners are rolled on, and that can be a cause of accident. And when you are aged, it is better than when you want to go to bathroom or you want to get up to answer a doorbell. Don't rush. Just get up from the bed, put your legs down for a few seconds, half a minute, and then you stand and very slowly walk. You don't be ashamed to use a cane or walker if you are not feeling comfortable. And then it is because of this cane, not only it will prevent fall, but it will give you more confidence while walking. So in this, that's my request to all of you, that hold your balance, don't be a fall guy. This is a picture from the famous cinema, which is called Fall Guy. This particular person is a stunt man. He used to do all sorts of difficult postures and maneuvers. But friends realize that we are not stuntmen, we are senior citizens, so we should not do something that will increase our life or liability to our next generation. With this, I end my talk, and I'll be ready to take any questions.
Thank you, Arvindo. That was a very nice talk and very clear and, for us to understand also. I just wanted to know that somebody who is born blind or loses sight in later life, what type of balance problem do they have?
Sorry?
Somebody is born blind.
Yeah.
And somebody who becomes loses sight after some age, what is their balance problem when they cannot see? The second part you tell is
Dr. Manacha, who are congenitally blind, yes, they usually don't have balance problems because there are other 2 parameters like vestibule and the proprioceptive sensation. They start compensating for that. They have got compensation. But those who have lost vision in the elderly, either because of very suddenly or gradually, they have balance problems because of 2 reasons. One is that one of the input, the visual input, which feeds the brain, which is the CPU constantly, is not there. So you have to depend on 2 other inputs to compensate. And second, they, because of their blindness, they are quite unaware of the surroundings. So they don't understand what is in front of them, what is in the side of them. So always, we see them carrying sticks, and they, with the sticks, they perform the work of the eyes. They rotate the sticks in front, sidewise, and they know while they're walking.
Yeah, progressive lens, if you have suddenly, there's a lot of problem initially actually.
Yes, certainly.
Staircase. And you must tell some few more things that at our age, we should never go down a stairs without holding the side railing.
Yeah.
Always hold a railing and sitting down.
They run down the stairs with the mobile, and they, that's why I put this slide of fall guy. We all think we are very fit, we are athletes, we can do everything, but we are not. So it is better, we should understand our restrictions and should follow that.
And never climb on stool and all to pick up things, from the top of the almirah and all that. That also can lead you to a fall.
Can I ask one question?
Sure.
What is the meaning of posterior canal stimulation? In the ear, posterior, because there is a report saying reduced score for right and left posterior canal stimulation. And this is for a patient who actually, we went to the neurologist. He got the vestibular function test done, and this was the result that came, because this patient had kind of fallen or sways little bit left and right. So what exactly does it mean?
30 seconds, I will explain. I mentioned in my speech that one of the major input component is the vestibular system. So vestibular system is like a balloon. It is situated in the inner ear, just behind here, inside the bone. So it consists of fluid and 3 semicircular canals. There are 3 canals. One is called horizontal, one is the anterior, and one is posterior.
Okay.
So this fluid continuously goes around the anterior, posterior, and the horizontal canals. So if commonly the condition of vertigo, which is benign paroxysmal positional vertigo, is due to some paralysis or some fluid current disturbance, and most commonly it affects the posterior canal. So what you are meaning posterior canal stimulation is that the sensory organs, which is called utricle of the semicircular canal, is being stimulated inadvertently because of the faulty fluid current flow in the posterior canal. And that is the commonest cause, though sometimes the horizontal and anti-vertical canal can also cause BPPV, but posterior canal involvement is the commonest cause of BPPV, benign paroxysmal positional vertigo.
Okay, so the patient has been given VOR, that is vestibulo-ocular exercise or something. Rehab. So now, would that kind of correct it, or would it only be a temporary kind of thing where?
So there are 2 ways of treating this. One is the acute treatment, whenever this is happening. So best acute treatment is a maneuver called Ipley's maneuver. The Ipley's. So this Ipley's. So what they do, they put your head down and rotate it to one side so that whatever was irritating your posterior canal comes out of it. So this is a very simple maneuver technique. And sometimes they add to it certain vestibular adaptic drug, which is called beta histine, for about 6 to 8 weeks. So this is for acute treatment. But to bring back your balance, there are several neurovestibular balancing exercises. One of them is the VOR. The VOR is very simple. What I told you at the first line of my lecture, hold an object in front of you, do like this, do like this, do like this, do like this. And that will improve your vestibular connection. This is what VOR is for.
So that is what they're doing. So the patient says they're feeling better. So hopefully it will kind of address it and the balance will come back.
Yes, it will.
Thank you. Thank you so much. And also I must really be happy because this patient is very closely related to me. it really gave me an insight into so many things about what could be happening.
Thank you.
Thank
I
you
tried
so much.
to abridge it, but I don't know what I could do it. Thank you.
Thank you so much.
Thank you.
We used to read in physiology that when you drop a cat from a height, they always fall on their feet. They have a good vestibular system, I believe.
Yes. Yeah. So, any questions?
Yeah, I have one question.
Yes, please.
Just Prem Goyal. The question I have is, are there any kind of supplements that we can take proactively to minimize these issues later on? Like I'm 50, I'm 60. So I'm trying to see what can I do now to avoid or delay any kind of issues happening in most cases.
I think I will answer it. We can have three modalities to follow. One, if you have any comorbidity, like if you are diabetic, if you are hypertensive, take good care of that, number one. That is because those are the precipitating factors. Number two, you check your fitness of the body, like all your micronutrients or your vitamin components, they are also good. If they are deficient, you take that. And third, I would say that you do regular exercise and particularly give emphasis on balancing exercises like walking tandem, walking forward, walking backward, standing on one leg. And a very common, if we can do, is that while you are untying your shoe, don't sit down, don't look for a tool. You just stand and try to untie. This will keep your balance okay. So there are certain medications which are in the market flooded with that. Some say that they increase your cerebral blood flow, they increase your vestibular blood flow, they bring back your balance. These are all rubbish. They don't do. So pharmacological agents, except for particular deficiency states or disease states, are of no help in the chronic maintenance of balance.
Okay, thank you, sir.
Doctor, this is Praveen here.
Yes.
Yeah. In the past 3 years, every year I've been falling down. Thankfully, I've been able to save my head. So, like when I start falling down, the first thing that comes to my mind is protect your head.
Right.
But then I have fallen down, and up till now, maybe it has happened for like about 7 or 8 times. So every time it has happened, the doctor's analysis was, after getting all the tests done and everything, it was electrolyte imbalance. And I was told to take a lot of salt. Like I went on salt capsules also. So just wanted to know that would be another reason for taking a fall.
So, Praveen, I'd like to know these 8 falls in a span of how many years?
See, actually, it all started after COVID.
So 3 years, 4 years.
So I took multiple falls in 22, 23, 24. So much so that 2 years I had to be even hospitalized for maybe 10 or 15 days to recover.
So, Praveen, it is very difficult to designate low sodium we call hyponatremia as the only cause of fall, because this fall due to hyponatremia, they are usually associated with disturbance of consciousness, sometimes with seizures. And
ठीक है, हम बाद में बात करते हैं. Sorry, doctor.
Doctor, I have
Low sodium, fall due to low sodium hyponatremia is usually associated with other brain dysfunction. It is not only a fall. Like there will be either drowsiness or there will be seizures like this.
No, I have been disoriented also.
Okay.
Yeah.
Then it is probably hyponatremia. That is the low sodium is the cause. So if there is a recurrent low sodium which is causing fall, we must find out what is the cause of low sodium. Normally, this sodium doesn't go low unless there is some cofactor which is causing your low sodium. Some of the cofactors, like if you take a common blood pressure medicine which contain diuretics, which contain urine flow, and that causes low sodium. So to deregularize this. Sometimes certain diseases can cause low sodium. Some kidney problem, they cannot handle the sodium properly. But in spite of all the investigations, if you don't fight, we call it a syndrome of inappropriate ADH secretion. So there is one hormone which holds the sodium back that is secreted inappropriately in excess. So it is holding, removing your sodium to your urine more than what it should be. This is called SIADH. So if you have a recurrent fall, sodium replenishment is definitely a cause, but there are certain medications which deregularize this excess ADH secretion. This is available in the market. So sometimes we put, in addition to high sodium diet, we add that particular medicine so that your sodium level is maintained. And avoid any medication which will make you lose sodium through urine.
Yeah, like I was told by the doctor that you are drinking too much water, and that is also washing out your sodium
But
or
if your
the electrolytes.
renal function is good, then only taking water will not cause low sodium. Then your renal function is compromised. Normally, say one healthy person takes 3 liters of water, it will not cause low sodium.
Okay. Fortunately, it has not happened
Yes.
this year or last year, and I just call it fortunate.
But you should be careful because I told these falls may be very benign, but the outcome may be quite a complicated outcome.
As a matter of fact, these days I have low balance also, and I regularly visit the physio, where she makes me do certain exercises for balancing.
Good.
And I do them. And also, I have a habit of walking. Like I like walking, though these days it is reduced quite a bit. But whatever walking I do every day, I am extra careful that I walk during the daytime, like when the light is there, and come dark, I don't like going out. But I can feel that my walking, I need to consciously maintain a straight line.
Yeah.
So all this, I don't know the reason, but there must be some reason why I'm having all this. By the way, I do have osteoarthritis in my left knee. So that adds up to the reason, like my left leg doesn't support my walking as much as my right leg.
Yeah.
Doctor,
anyway,
may I ask, sorry, can
Yes.
I thank
Sure.
you so much for your this presentation. Learned a great deal and it was so informative.
Thank you.
And I just have a clarification, doctor.
Yes, sure.
Did I mishear or something that stand up and wear our shoes For better balance, I thought we should sit and wear our shoes.
That is very difficult for our age actually, because my son-in-law, when I went to the USA, when he's going to the hospital, he used to stand and
Yes.
tie his shoes. He showed me this is the balance. He could do what we cannot do at this age, standing and tying our shoes, I'm sure. Even Amitabh
Okay,
says not to wear your trousers standing. He says sit on the bed and wear your trousers.
Dr. Manoj, I will not contradict you because I will not take name, but a person of my age, he can stand, wear his shoes standing and do the socks, and he is very disturbed if I want to look for a tool. Well, why you are looking for a tool? Try. So I think if we had started early, maybe when we are a bit younger, this can be done. You can maintain a balance.
Anything with practice, you can do it. Yeah,
you can do. Yeah, it is not impossible that, after 65, 70, you cannot do it. But it is a very good practice. One is that it increases your balance, and number two, it gives you information what is your status of balance.
No, in our pediatric practice, we almost get a patient a month. The child in the school, in the assembly has fallen down and sent home. I just tell them that this is vasovagal and nothing is required. But even soldiers standing for a parade, they also fall down. They are very healthy. But you see soldiers also.
That's a simple. But this wearing your shoes standing is a very good exercise.
Yes, that's true.
Okay, next time I'll try. Thank you, doctor.
Don't fall, but.
I'll come to you.
I had one small question, basically related to fall. Is a fall simply an accident? Or should every fall in an elderly person be considered a symptom until proven otherwise?
I think your second comment is more appropriate. Not all falls are accidental. There may be some background reason of fall which are not being looked into, and if we ignore that, there will be recurrence of fall and serious complications. So some of the falls may be accidental, tripped, slipped, etc. But once if there is a recurrence and without only obvious reason, then he should be evaluated for some background disease.
Okay, any further question from anyone? So if there is no question from any other participant, then I think we come to a conclusion that thank you, Doctor, once again.
Thank you. My pleasure.
For an extremely meaningful session that we had today, which is extremely critical for all of us. All of us are almost 70, 75 plus now. And it's very critical for us to understand why this happens and what are the things we need to be careful about. Thank you once again for an extremely meaningful session. And it's nice that you joined us again for the second time. The first time was also equally interesting that we had.
No, and Dr.
If I recall, the first time when you had, we had the maximum participants joining in during your session. It was on dementia, I think.
Yes, dementia.
And Doctor, we are very thankful that for you to readily agree. The moment I called you, you immediately
No, my pleasure. I like to talk. Only, I need some listeners.
You like to talk and we like to listen to you. like another friend of ours, there are quite a few friends now in your doctor's community. One is, of course, Dr. Manocha.
Yes, is there.
The other is Dr. Siddharth.
We have five classmates sitting today here. Vimla Chayal is a classmate. Amitabh Datta is here. Siddharth is here. So we have 5 doctors from our class today. And we are together from 1967. We are together actually.
I know. But you guys have been together.
Yeah.
But we have been recently introduced to you.
Yes.
But we feel so easy talking to you guys, and then of course I will not take Asha's name because um, uh, I have been knowing her for a long time, even before I knew you. But even Dr. Manocha's daughter-in-law, Chandrima, you
Yeah.
know,
Thank you. Thank you, Praveen.
well, here, but
Thank you, Praveen.
okay.
Bhupendra Manuja forgot me. I'm also
No,
listening.
sorry. Sorry. I
So
mean, now you've shown your face. Why didn't you show your face before?
the best thing is that your group is such an easygoing group, you know. So that's very nice, very nice.
My
Thank you,
sister used to
Praveen.
know. My sister's ex South Point, so she knows you for ages. You know, like she's no
And,
more now.
Oh yeah,
and Praveen's mother taught me in my school in Baliganj, Sadan.
it's a small world.
It's a small word.
Yeah.
Yes. Okay.
So thank you,
So,
doctor, from
Thank
all
you.
of us, and I think Arun has already, and
Thank you.
we will look forward to seeing you guys now away from these lecture sessions.
Sure. Sure.
I don't know,
Thank you. Bye-bye.
maybe the next time.
Thank
Okay.
you.
Thank you.
Thank you, everybody.
Bye. Good night,
Thank
everyone.
you. Good night.
Okay, then I think we call it a day and look forward to all of you again participating for the next one session. We have another interesting one, which will be coming to all of you in a few days' time. Okay, doctor, thank you so much once again.
Okay, bye, everybody.
bye.
We are.
Bye bye.
Bye,
Good
everybody.
night.
Okay,
Thank you
bye-bye.
and bye bye. Oh,
Bye,
Asha,
everyone.
yes. Thank you and bye bye.
Oh, hello, Sudha. How are you?
I am fine.
Ah,
Man,
good.
Suriti Sara.
Oh,
I
good,
was
good,
here.
good. Good. So nice. So
Thank you.
nice. Thanks. Bye.
Where's
Bye.
Sudha? I haven't seen her.
Ah,
Where is
Yeah,
Sudha?
and another doctor,
Put it out.
Anubha. Anubha is also there in our
Yeah.
group.
Yes, and it's thanks to Anuba that
Yes, we got
we
together.
were introduced to you all. It's
Yes,
really thanks to Anuba.
yes. She's in USA right now.
Yes,
Okay.
yes.
Yes, yes.
Yeah.
Okay. Thank you, Godhidi. See you.
Bye bye. Good
Bye.
night.
Bye.
Good night.
Good night.
Bye.
Good
Good
night.
night.
Bye.
Bye, Sudha.
Bye. Bye, sweetie. Bye.
Bye.
And thank you for informing us and keeping us
Yes, and
informed.
thank you for joining this time. Every time
No,
I
no,
say
this time I could join because I had no other disturbances, people around and things like that. Sometimes I just can't, even if I want to, I can't join.
yeah.
Thank you.
Okay.
Bye bye, everyone. Bye.
Bye.
Good
Bye
night.
bye.
Good night.
Good
Bye.
night. Good night. Good night.
Good.
Dr. Tayal was my daughter's gynecologist also. That was, of course, some time back. Amrita Chaube. Oh.